Hi, thank you very much for the invitation. I'm the warm-up act for Patricia, who's going to talk about patient involvement. I'm just going to set the scene. I'd just like to thank Chrissy for that fantastic presentation. Whether you believe it or not, when I went to medical school, I had long, flowing locks, and the professor of medicine told me there was no way I was coming near his ward with long, flowing locks. So I had my head shaved for the local hospice. And you look very nice with your head shaved, where I just look like a thug. So it was nice to see that it can work both ways. Over the years, I've talked to a lot of people about anticoagulation. I've come along a journey since the end of the 90s when I joined my practice in Shipley, a small town just north of Bradford. Nobody's heard of Shipley, but a lot of people have heard of Saltaire, which is the attractive end of Shipley, and a World Heritage Site. And a lot of what I do, particularly as a general practitioner, is around prevention. So when I got into anticoagulants, it was when I realised that trying to prevent stroke in patients with a heart rhythm disorder called atrial fibrillation, which dramatically increases your risk of stroke, I was talking to patients who were making that decision about their clinical care on bus routes, because the only warfarin clinic in our city was deep on the south of the city, which would have to go through Bradford Interchange. Now, any of you who know Bradford, and I don't care whether you're from there or not, Bradford Interchange isn't a nice place, particularly if you're an older person. And I didn't like the fact that people were making life decisions on the availability of what was a service we could offer in the north of the city. So I took it on myself to learn about warfarin and set up a warfarin clinic. And I've been along a road of anticoagulation ever since. Now, another statistic that I picked up from the professor this morning, which I think is something else to reflect on, is the fact that of those patients who have found positive of factor V Leiden, 95% of them will not suffer a clot. Now, as I look around this room, anybody who gets over the age of 45 has a 1 in 3 chance of suffering from atrial fibrillation within their lifetime. And they have if you have AF, you have a 1 in 3 chance of suffering an AF-related stroke. So although we're talking about thrombosis today, the access to anticoagulation is really important for a very large proportion of the population. In the over 65s, 1 in 10 people has AF, and about 90% of them should be offered an anticoagulant. So how do they go about accessing that? Now, of course, what we have is we have new agents, but I don't want people to forget that we've also got a very, very nice old agent. And I talk about warfarin with my patients, about the fact that as a scientist in medicine, I love warfarin. It's a little bit like opening the back of your watch and having a digital watch and seeing a battery, or having an old-fashioned pocket watch and seeing the beautiful intricacy of all those little cogs working together. They both tell the time, but if one of them drops, it's more likely to break. And so warfarin is beautifully complex, but is going to find a future where fewer of us have that in our pocket compared to our new digital alternatives. So what's its major problems? And you will probably know this better than me. It has this horrible interaction with our life, in the fact that when we're on warfarin, our life can be controlled by the drug. I have to say, I tend to run my clinic saying, you run your life and I'll try and adjust your warfarin accordingly. But I know that's not the experience that many people get. It does annoy me a little bit as a doctor, because virtually everything I'd like to prescribe to you will make your warfarin go peculiar. And that means you're back in the clinic all the time. So it gets in my way, as well as your way. And, of course, as a doctor in a different setting, if I was based in a hospital, of course, I get quite annoyed by the fact I can't just stop warfarin and it stops. It has to go on for a little bit to remind me that it's there. So it has a few disadvantages, as well as doing what it does remarkably well. So I don't want to be seen as standing up here giving an anti-warfarin talk. I'm a very big fan of warfarin, but I think people should be given choice. Another problem with warfarin, of course, is this narrow therapeutic range, although I don't think it's quite as narrow as many of the new drug companies would like us to believe, but it is a problem for us, and not only for us as doctors trying to manage it, but for you as patients trying to live with it. So I think we've got to try and find that balance. And then we have new agents on the way. Medicine is beautiful, it moves forward like an express train, and not to disagree with the Prof, the idea you can keep up with it is quite scary. So what have we got in its place? Now, what we have are the new oral anticoagulants, except from we're not allowed to call them new. So anything that's been licensed for over a year, the company can't call it new. So we could call it novel. Now, the Prof can correct me if I'm wrong, but it's not particularly novel, because actually we've been attacking this part of the coagulation cascade for a while. So there's been a bit of an idea that we could call them direct oral anticoagulants, and I'll try and highlight why that is. I've got a feeling that a company that specialises in warfarin or monitoring of warfarin came up with Tossax. That seems ever so slightly insulting. But we've managed to come full circle and come to the idea that we might call them non-vitamin K antagonists. Since the acronym is so well known, I think we need to try and get our Times crossword solving people to try and keep the acronym in use. So we're going to stick with the NOACS. Now, this is a simplified version of the coagulation cascade, and I've done it to show how beautifully complex it is. Warfarin hits it in several different locations. So warfarin is affected not only by where its target is, but how long those targets take to be controlled. So that's why it takes a little bit of time to get up to target, and also why when we stop it, it takes a little bit of time for things to recover. As the name suggests, these direct inhibitors do attack much more specific foci. So when we look at how they work, dabigatran, which is one of them, affects thrombin, and the other ones affect 10A. Okay? And there's two of them currently on the market, apixaban and rivaroxaban, and there's another one on the way called edoxaban. And for those of you who like collecting trivial pieces of information like I do, if we notice they all end in exaban, 10A-aban. Yeah? Edo is the old name for Tokyo, which is why the next one, coming from a Japanese company, is called edoxaban. So it's from its Japanese origins. Useless fact, but I bet you'll remember it tonight. So what do we want from an anticoagulant? We want it to work. So the first thing we have to do is say, how do these drugs work compared to our gold standard? And our gold standard is warfarin, because warfarin does its job remarkably well, particularly in atrial fibrillation. We want people to be able to take it as a tablet. I don't think any of us would say that we enjoy being injected. It'd be nice if it started when you started the tablet, and equally stopped when you stopped the tablet. So it'd be nice if it was rapid. It's nice if it was predictable, so I can't muck about with it with my medication, and you can't muck about with it within your life. You just take the tablet and it does its job. So it doesn't have any food interactions. And it'd be nice if we could stop it in an emergency if we really needed to. So we'd like to be able to stop it dead. Okay? Do the NOACS fulfill this? And the answer is, on the whole, yes. Now, this is where they're coming into the marketplace. It all started with hip and knee prophylaxis, so the kind of thing you would get if you're having orthopedic surgery. As many of you know, orthopedic surgery is a big risk for thrombosis. But they've also been studied in very extensive studies looking at atrial fibrillation, where they were looked in comparison to warfarin and found to be non-inferior. We can discuss whether or not they're superior in the next session. But at the very, very least, they're non-inferior to a very, very good treatment. They've been studied in venous thrombosis, where in DVT they've been found to be as good as the alternative pathway, and actually, in pulmonary embolism, they look like they're safer than the traditional pathway. So it does beg the question, why are we not moving forward to make more people be able to access these medications? And one of them also has a license for acute coronary syndrome. Now, these are important numbers. and I've made the slide look complicated on purpose to allow me to explain it. TA is a nice acronym. It means a technical appraisal. So quite often when we see or hear of medication in the media, the reason we hear about it is because NICE has had its evil way with it and said, thou shalt not, and you can't get access to what looks like an exciting medication. Now, what NICE has done is it's done a cost analysis. It's done a technical appraisal. Okay? Now, a technical appraisal for these drugs have so far not denied any of them from patient ability to take them. They all have positive technical appraisals. Now, what does that mean to the person in the consulting room? It means that after 9 months post a technical appraisal, your local commissioning organisation has to give you access to these medications. It's not a choice. They can't decide to ignore this. This means that you have the right of access. Okay? I speak to a lot of GPs and I explain to them that with a positive TA, the local medicine advisory people cannot say you cannot prescribe them. They may make the pathway to receive them very complicated, but they cannot say you can't have them. And as you can see, in all those boxes where I previously put a cross to say this was an indication, all of them have a positive technical appraisal. So you do wonder why, particularly in the treatment of DVT, where they have a clear advantage in the pathway of care for the patient, we see their use in Westminster, we see their use in Sheffield, and we see their use in Bradford. Why? Because we've had people who have advocated the change in pathway to ensure that people have access. These are not banned drugs. NICE likes them quite a lot, actually, and NICE is wondering why we're not using them. So what about a few of the myths? Maybe we've just been scared, okay? So firstly, we don't have the experience with these new drugs. They're not new drugs. These drugs have been available to the likes of the prof for some years. The orthopaedic staff have been using them. And no disrespect to my colleagues in orthopaedics, medicine doesn't regard orthopaedics as the academic altitude. It tends to be elsewhere. And they're using them all the time. So surely experienced clinicians elsewhere in the profession can also have access. A recent study was looking at dogs detecting gastric cancer. Did anybody see that? A study that showed that we can get dogs to detect gastric cancer. That study had 150 people involved in it. Amazing work. The last piece coming out of the FDA in America about the NOACS had 72,000 patients involved in that work. So I don't think our lack of experience is truly an excuse. We can't monitor these new drugs. I think that's a concern for some hospital-based practitioners, but actually as a GP, I don't monitor many of the drugs I use. I definitely don't monitor aspirin, which seems to be one of the major alternatives. So I don't know if that's truly a concern. When it needs to be surveyed, we can see that our colleagues in the hospital can survey it. For those of us in general practice, we just need to reliably understand it works. We can't reverse these drugs. As I've already said, these drugs have remarkably quick onset and offset. So our need to reverse them compared to warfarin, which will have its effects for 3 or 5 days after stopping, is less of an imperative. And the antidotes to these drugs will be available probably by the end of the year, if not early next year, again, for our colleagues in hospital practice who may need to reverse them in an emergency. They'll bankrupt the NHS. Everything's going to bankrupt the NHS. Okay? These have all been shown to be cost-effective medications. And none of that work showing them to be cost-effective actually took into account the personal cost of patients who have to attend warfarin clinics. When we look at warfarin clinics, we look at the mechanics of the clinic. And even then they were cost-effective. Once we start actually financing in the patient's time of getting to and from and often spending half a day in the clinic, I think we may find the maths actually goes in the opposite direction. The clinical commissioning groups can say no. No, computer says yes. NICE says yes. So they do not have the power to deny people access to these medications. And if they're being denied to you and your local health community, we need to do something about that. You must have warfarin first. Nobody said that. If you look at the new NICE guideline for atrial fibrillation, one of the major areas where anticoagulation comes into the system, most people in an anticoagulation clinic are there because of their heart, not because of their thrombosis. There, it says the choice is completely with the patient and their right to choose. You won't try warfarin, you can have... That, again, rubbish. You have the right to choose your medication. And I've actually heard of patients who've told me, they've been told, because I said no to warfarin, they won't let me try the alternative. Rubbish. You only can have it... This one's positively dangerous. Because surely that means if you want to have access to the tablet, you just start erratically taking your warfarin to crash your control. Who could possibly put that forward as an option? You must take them regularly every day. That's actually true. Okay? 20 years in medicine, and one thing I have learned is that if you don't take the tablets, they really don't work very well. But these are all worries and concerns that are being raised by patients and by GPs and commissioning groups, and most of them are incorrect. What we now need to do is we need to change this. Now, how do we change this? I have to say at that point, I'm a massive advocate of listening to the patient voice, and I think we've really got to get people involved in their local health communities, taking your expertise from a national meeting like this and making sure it's focused back into the practice or the local hospital where you're based to ensure that you, but not only you, other people who are less well informed get a quality of care that you are aware of. Now, I'm not an expert in that, but I happen to know a woman who is. So I'm going to hand over the platform to Patricia.
Good afternoon, ladies and gentlemen. Can you all hear me? Yes, thank you very much. I'm Patricia Wilkie. I'm chairman. I feel an interloper here, but I've been very kindly treated. I know nothing about this subject, well, almost nothing. I'm president and chairman of an organisation called NAP, the National Association for Patient Participation in Primary Care. Founded 40 years ago by GPs to improve the quality of primary care through patient participation groups. We reach out to some 8 million patients in the UK, going up all the time, and we're now GP practices by contract must have a patient participation group. It's not a tick box any longer. So do go and ask your GPs if they have a patient group. And is it affiliated to NAP? And what I propose to do when I go home today is to ensure that there's some information on our website about the organisation so that it could be publicised throughout. We're a UK organisation, so it'll be published UK-wide. Now, I've started with the flick, sorry, I beg your pardon. I've started with this as a person. And this is really a message, and I don't think I need to say it, to my clinical and medical colleagues. We are not a heterogeneous group. We come from different backgrounds, different culture, and we heard how important ethnicity was this morning. We are alone or we are supported. Some people today, some of the patients who spoke so eloquently, were very supported, but there must be out there people, and in fact there is somebody I spoke to this morning who is not so well supported and feels at times isolated. So when we have a problem as serious as this, we must remember that we're not all the same. Now, we're also citizens, and I've put this up because we have legal rights in the NHS, including the right to drugs and treatments approved by NICE in England and SIGN in Scotland. I mean, that is a right, and it is free at the point of delivery. Please don't say it's free, because you pay for it through general taxation, but it is free at the point of delivery. Perhaps even more important is we have the right to be given information about the test and the treatment options available and what they involve and their risks and benefits. I'm not a medical doctor, I'm a social scientist, but I did my PhD in psychology and looking at risk of inherited disease. And one of the things I learned was that if you say to somebody, you have a 50-50 chance that you will develop something, it also means that you have a 50-50 chance that you will not develop something, and it depends how that information is put to you. But as a citizen, we have an obligation to use the NHS wisely and not waste scarce resources. How often do we read that people who go and tidy up a house after somebody's died, that there's a kitchen cupboard and a medicine cupboard and a bedside cupboard, all full of pills that have never been taken? Is that using it wisely, or was it bad prescribing, or what was it? Now, the patient. Patients should be able to expect honest information from doctors. I'm not suggesting for 1 minute that doctors are dishonest, but the information is sometimes minimal. We don't get all the information that we should have. If one comes back to general practice, how many people here know that if you are prescribed, for example, a statin, the doctor gets paid separately for that? Thereby hangs a tale. And that is why, in some cases, GPs are wanting to make sure that people are on certain medication. And why, if one reads Margaret McCartney's little book, which came out last year. She's a GP in Glasgow, a friend of mine, and she's a great journalist. She writes very well. It's called The Patient Paradox. And she says how irritating it is when she's consulting, because up on the screen comes things that jump at her, tell her, have you taken the blood pressure? Have you done this? Have you done that? And she's listening to somebody whose problems are very great, and these are just a distraction, but these may be to do with cough points. We all need to feel able to question GPs and doctors about the appropriateness for us of proposed treatment. I think that's very difficult for many of us. We need to write down what we're thinking about before we go. And if it's a hospital consultation, maybe a bit longer. GP consultations are often just 10 minutes. And that 10 minutes can go by so quickly if we don't know what we're going to say. We may not have the confidence to ask if we didn't hear something properly or if we didn't understand. Can you write it down? Can you give us a copy of the letter, which we're entitled to? Can you explain it again for us? We need, even more importantly, to be encouraged to be partners in our health care. All of you who are here today as patients are active partners in your health care, and that is admirable. But there are many, many who have not reached that stage yet, and how difficult it is to get the information in order to make the decisions. The final point I would like to raise, it has come up today, but I'd like to emphasize it, is that doctors need to learn to share uncertainty with us. Matt did just now, but how often do doctors really share the uncertainty that they have. And we need to share the doubts that we have. And once we're on that footing, we're on a much better way to be able to manage our own care. I've been very brief because I know that there's a lot more to come this afternoon, but thank you for listening.
That was fantastic. What a fantastic dual act. Oh, no, you can't escape. Come back. Go back. Matt, do you want to come up? Now, who's got questions for these two? Right, here we go.
Hi, I don't know where to hold this. I was diagnosed with DVT in 2012. I started on warfarin, and then I had a stent inserted in towards the end of 2013, at which point they started me on rivaroxaban. I then had the stent stretched up about 6 weeks ago, and after about 4 weeks of heparin, I'm back on warfarin again, and the plan is to have me on warfarin for life. I don't know if you're able to answer this, but what are the differences there, and what I was told that rivaroxaban was not appropriate for my treatment going forward.
And the problem there is about licensing. You know, if we haven't done the study, we don't know the efficacy. And you sound like you have a very, very particular issue. I would suggest that it's about personal preference of your surgeon, to be fair.
Are there differences between rivaroxaban and the other new drugs? If
The new drugs are very good at doing what they do. And so I'm quite often asked what would happen if I went into AF, would I have warfarin or one of these new drugs? And for me, it's very easy. I've got a peculiar heart, and so I know that it hasn't been studied, and therefore there's a reasonable level of uncertainty as to whether they would work in my particular setting. What I've got is less than 1% of the population, so the study population isn't there to answer the question. So I probably would go for the certainty and say, this is what we know, and we're certain of that, rather than the potential uncertainty of using it in a new situation. What happens over time in medicine, of course, is due to necessity, newer options are used in rarer and rarer alternatives. People who can't take warfarin but must be on an anticoagulant, and we learn through experience. But would I want to be the early adopter with my heart in my chest? I don't know if I'd want to be the early adopter when there's an alternative available to us where we have more certainty about its use. And I would suspect that kind of conservatism with a small c is inherent in all doctors, that we like to go with where we're certain to start with and only get pushed into these areas when life is making it so we are pushed into those areas. I made a lady completely and utterly bald on warfarin, and she's never going to have warfarin off me again, but she's now on an alternative. So it's about experience.
Thank you.
Hi, I can't take the new anticoagulants as I've had a PE with an INR of over 2.5, I think. But at some point, like you say, it may be that there's enough information and enough testing that I would fall into the category which would be licensed. So I'm just wondering, with the shorter half-life of this drug, somebody that's high risk like me, I understand you have to take it every 24 hours. If you, I don't know, for whatever reason, you get stuck and you don't have the medication, how soon after that 24-hour period are you exposed? I guess one of the problems with warfarin being that it has this longer half-life is also there to protect you as well. And although my INR may go up and down, I don't really think in the time that I've been treated that I've probably ever gone within the normal range of somebody that's not being treated. So I don't know how long I'd have to be completely unprotected to have another problem.
As a kind of a rule of thumb, if you skipped your tablet and you're halfway to the next dose, so 2 of these tablets are twice a day, 1 of these tablets is once a day. If you're halfway through the time period to the next dose and you suddenly remember you should take your tablet, if you're beyond that, then you probably should wait for your next dose. I think clot is, personally, and I'm desperately conscious of the prof stood there, clot is much more dynamic than I think many clinicians give it credit. And even if we look at warfarin, where its time in therapeutic range is at 70%, it achieves incredible things, even though 30% of the time it's out of range. So I think that we're still learning a great deal about these drugs. The second question, which was inherent in what you were saying, is what do we do with those people who need higher range INR? And with the 10A inhibitors, which it seemed to be the more commonly prescribed, rivaroxaban and apixaban, I think that we won't see them used where we need to see higher range, because so far the evidence is that when we've looked at them in those kind of settings, they don't look very good. So those of us with dicky heart valves, I think we will be committed to warfarin and for the foreseeable future.
So, I mean, we have only done trials. All the hundreds of thousands of patients that have been on NOACS have only been running equivalent to an INR of 2 to 3. But we are starting some trials giving bigger doses for people with an INR of 3 to 4, but we need to do trials, definitely not to give it to patients until the trials are done.
An interesting situation in one of the studies, the Einstein study, was one of the patients actually took their whole 3 months in a single day, and they didn't bleed more. Now, if you did that with warfarin, as many rats will attest, that's not a good thing. But with the rivaroxaban in Einstein, it didn't actually induce more bleeding, and it looks like it may have you just can't take it that far. I wouldn't test that. Anybody who's on rivaroxaban, I really wouldn't test that. But it's an interesting
we have
situation.
had a patient who overdosed on a NOAC, and they took 20 tablets, and they're fine.
Yeah. Interesting drugs.
Right, I'm on lifelong warfarin, and I was put on the new anticoagulants last June. And within a week I was in hospital, so my body didn't agree with the new anticoagulant. I didn't give up, tried 4 months later again, and got a gastrobleed. So how more likely is it to have a gastrobleed than a warfarin?
I think, again, it's choice of drug. We know, and it was actually just published in the BMJ this week, actually, yet more information about the fact that they seem to have a higher level of GI bleeding. So if we look particularly at dabigatran is a drug wrapped around an acidic core because it needs an acidic environment. And so the incidence of heartburn in that study was up about 20%. So we know that they cause issues there. If we look at all the new drugs, it would look actually that warfarin and apixaban have similar levels of gastrointestinal bleeding. So in my patients, if they say, I really want to be on one of these new agents, and I know they've suffered a significant gut bleed in the past, I'd probably go to apixaban. But this kind of nuance is what you're going to get with those of us who are using them quite a lot, so we can see the little differences between them all. Where my advice to most GPs and to most health environments is, as we're learning about these, that you choose one of them and we all learn together. So the GPs learn, the patients learn, because we know we all talk to each other all the time. So you learn about it, we learn about it, the hospital learns about it. And the risk that you're going to be on a medication that some junior doctor at the front line in the hospital doesn't recognise the name of, and therefore gives you a second anticoagulant, and it's happened, it is much less. But if you're in that setting, you need to be talking to people with much more experience about these new agents, because there are subtleties between them. And that's a situation where I'd break from Bradford's rivaroxaban community and go to an alternative. The big advantage in that situation is warfarin's very, very reversible if you have a big bleed. Yes. Sorry.
Hi, I just want to ask, you're pushing these drugs that you've mentioned today. I've never heard of them. I wasn't even given a choice. I was just told warfarin was going to be my lifesaver and I'm on it for life. And you're on about patient choice. I'm not quite sure how we choose if we don't know what we take, and we trust what the GP says and say warfarin's best for you, whatever. And mine give me a omeprazole, and I was quite touched by that little sort of TLC bit, because that's the only support I've had, just because he said it would, you know, irritate the gastrointestinal lining, and that was it. So how do we go about finding out about these drugs to have a choice that's better for us?
I would refer you back to my conflict slide, where I also highlight the fact that I'm trying to have a wide voice on this. So I have the delight of being one of the trustees of Thrombosis UK. I'm getting there. Also, I'm involved with the AF Association and Anticoagulation Europe, and areas where these drugs are being used, because it's through those kind of support organisations that people start to learn. I then think that you get the fact that in my practice, I host the Bradford Arrhythmia group, and in that group, patients are teaching each other about their different experiences. They're then going back to their individual practice groups saying, how come if you see Matt Fay over there, you don't have to go to warfarin clinic, but if I'm over with you, Nick, I have to go to warfarin clinic, and we spread the voice. What I would prefer, and I don't know if we have any colleagues from industry in, is I much prefer that it goes that way, that it comes from the patients and from the advocates and experts teaching patients, rather than the idea that we end up in America where it's an advert on telly saying, go and ask your GP for this. It might make you bleed to death, and then you can sue them by slick and oily, the lawyers who follow them in the adverts. You know, so I think it's important we teach each other, but I think it's a very good question.
Now, this session doesn't quite finish because you can interrogate Dr. Fay during the workshop. So I know other people have got questions, but we need to come to an end. I know Patricia wanted to say one last thing.
Well, just one last point. I said at the beginning that I know very little about this, but 15 years ago, we took my 92-year-old mother by car to Switzerland, where our daughter lives. When she was there, she had a deep venous thrombosis, and was treated impeccably, may I say, in a big hospital in Geneva. The treatment of choice was heparin. I asked before I brought her back if she could have this treatment in the UK, and her, oh yes, there was no problem, but I was given this amount of references why heparin was the treatment of choice. An appointment was made with a hematologist at the DGH where we live, and they said, this person said, no, warfarin with the same pile of different references was the treatment of choice in the UK. Eventually, and that's what she got, eventually nobody could bleed her except me, and I was left for the last year of her life. She lived till she was 97, almost 98, doing her test every day and the INR. But she was known in the family as the Duchess because she had a look, and she hated this. It was sore, and of course I got the look, so it was not particularly nice to be in the position of doing that. So I have just a little experience.
Right, so thank you very much, both of you, and I'm looking forward to you joining us later in the workshop.